All right, everyone. Hello. Good morning. So, on behalf of Screen NJ and Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And now I have a few more announcements before we begin the presentation. This is just a quick disclaimer that the information contained in this presentation is not a substitute for medical consultation, and the physician should always be consulted for any health problems or medical conditions. So today's agenda, we're going to do a Project Echo series overview, go over some introductions, do the actual presentation, we'll have a case study, and then we'll do questions and answers at the end. So a little bit about Project Echo. The Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. This is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, and applying case-based learning to master complexity, and evaluating and monitoring outcomes. For more information, you can check out Project Echo dot or is it echo.unm.edu online. So our introduction. So today we have Cecilia Gomez, and she's going to be doing the didactic part of the session. Cecilia is a bilingual community cancer control specialist with Rutgers Cancer Institute. She graduated from Montclair with a degree in nutrition and public health in 2019, and has been working in nutrition education and chronic disease prevention ever since. She worked at the Community Food Bank of New Jersey as a SNAP Ed nutrition educator for 3 years before coming to Rutgers Cancer Institute in 2022. We have Janet Acosta Hopscheit, and she's going to be doing the case study today. She joined Hunterdon Health in 2014 and rejoined in 2024, where she coordinates the New Jersey Cancer Education and Early Detection Grant Program to assess and enroll underserved residents in cancer screening services. In addition to this, she provides community health education and stresses the importance of having annual cancer screenings. Formerly, Janet worked as a research health educator at Rutgers Cancer Institute, where she conducted cancer clinical trial education to students, medical and public health professionals, and to the general community. Janet has a bachelor's degree in microbiology from the Inter-American University of Puerto Rico and a master's degree in public health with certifications in health management, policy, health education, and promotion from Benedictine University in Illinois. She's bilingual in English and Spanish, and Janet is also a certified health education specialist. She's committed to ensuring that health equity practices are embedded and achieved in cancer prevention program services. And I'll let Cecilia take over now.
Thank you so much, Sarah, and good morning, everybody. Thank you for being here today. March is Colorectal Cancer Awareness Month and National Nutrition Month, so I'm glad that we're all here today. Next slide, please. So we do have a pre-test just to see what you already know, and we will go through the answers at the end. True or false, more than 60% of colorectal cancers can be prevented in the US with screening. True or false, fiber feeds the good bacteria in your gut. And true or false, stool-based testing that is completed on an annual basis is an effective screening tool for colorectal cancer. I'll give everybody a moment before we move on. Okay, great. And so what everyone, I hope, will take away from today is to understand the risk factors for colorectal cancer, be able to apply the current nutrition knowledge for colorectal health and cancer prevention, and to encourage yourself, your friends, and family to seek the appropriate colorectal cancer screenings and all cancer screenings. So we're just going to briefly touch on anatomy. We see here the colon takes up a large part of our body. It's known by many different names, including the large intestine, the bowel, and the gut. It's a major part of our digestive system and is responsible for synthesizing certain vitamins and transporting food waste out of our systems. When we talk about digestion, it's important to remember that digestion starts in our mouth, right? When we think or see food, our mouth starts to water. That is actually the beginning of digestion. And then food travels down to our stomach. And once the food reaches our stomach, it's further broken down into a liquid that is sent to our small intestine for absorption. Your small intestine absorbs most of the nutrients. It breaks down carbohydrates, fats, and proteins that fuel our body. And then the small intestine sends its waste or any undigested food to the colon for removal. The colon or large intestine carries and transports the weight to our rectum for storage, and then our anus for removal out of the system. And so that is a bowel movement. The colon is made up of a few different parts. It starts on the right-hand side of the body, where the small intestine connects to the colon at the cecum. The cecum is the first part of our colon that receives the liquid and food waste from our small intestine. And then it moves up through the ascending colon, across our abdomen in the transverse colon, and finally down our descending colon, which is on the left-hand side of our body. The very last part of the colon is the sigmoid colon, and it's shaped like an S, and that is just before the rectum. So the colon is actually 5 feet long. It's 3 inches wide and muscular, and it's shaped like a hollow tube. This is an image of a healthy colon where we see the tissue is pink and free from any polyps. And in this video, we'll see the colon in action. We just see this is a bowel movement beginning to happen, and this is actually the muscle at work as well. The colon is actually also responsible for absorbing liquid. It drinks for us. And that's what we see happening here. And then finally, removal of the excrement. So our colon typically absorbs 1 to 1.5 quarts of water per day. And this is why it's so important to be hydrated, because when we're dehydrated, the colon is going to reabsorb up to 5 quarts of water per day. And where is it getting that water from? It's getting it from the bowel movement. And that's what can cause constipation. That's what can cause painful bowel movements, dry, hard bowel movements. So it's really important to drink enough water, especially as the weather gets warmer and we sweat a little bit more. Very important to stay hydrated. And so what is colorectal cancer? Colorectal cancer is a cancer of the colon or the rectum. All of these cancers start from a growth called a polyp, and polyps are typically harmless at first. And they're quite common. It's estimated that about 30 to 50% of people will develop a polyp at some point in their lives. But if these polyps are not detected and removed, they can become colorectal cancer. Typically, this takes about a decade to occur, and that's why when we talk about the screening guidelines a little bit later, we'll see that it is usually 10 years between each screening test. So we're actually going to take a look here into the colon, and we'll see a few polyps in the video. So there's a polyp, there's another one, and this is a very stylized video of what a colonoscopy might look like, right? So we're going to take a look at the few different types of polyps in the next slide. This is a pendulocated polyp. There are two different kinds of polyp. The first is called a pendulocated polyp, and as we saw, it's very visible and easy to detect. It looks like a little tree, very easy for the doctors to go in and remove during a colonoscopy. The next polyp is called a sessile polyp. This is a little bit harder to detect because it is flatter. It looks just like a little bump. So that's why it is so important to get regular screenings, just in case something is missed. It's not usually, but it is really important just to be aware of that. And now we see here colorectal cancer. And this is, again, what happens when a polyp is not removed and turns cancerous. As you can see in the image, it's very red and inflamed, and it looks very different from the healthy tissue that's surrounding it. If it's not treated, it can metastasize and spread. So just like most cancers, colorectal cancer does have different stages. Stage 0 cancer is referred to as carcinoma in situ. This means that the cells are abnormal and have the potential to turn cancerous, but they're not cancerous yet. It's not growing at this time, and it is very easy to treat. In stage 1, the cells are cancerous, and they're growing through the first layer, tissue layer of the colon, which is the mucosal layer. In stage 2 cancer, the cancer is growing deeper. It has grown through the mucosal layer and the submucosa, and it is now growing into the muscular layer of the colon. A stage 3 cancer grows through the 4 layers of tissue in the colon, and it is now impacting the lymph nodes and blood vessels. Stage 4 cancer is where cancerous cells metastasize or travel to different parts of the body. This is where it is most aggressive and difficult to treat. Typically, colorectal cancer spreads to the lungs, the liver, and the bones. And so it is the most serious stage of cancer. We want to we want to screen and detect cancer as early as possible before it gets to stages 3 and 4, preferably. You may be wondering, what are some symptoms of colorectal cancer? And the most important thing to know is that usually in the early stages, there are no symptoms. Symptoms will usually show up in stages 3 and 4. So that's why it's important not to rely on waiting for symptoms to go and get screened. You want to get screened as soon as you are eligible according to the guidelines. Um, but the symptoms that are most common are fatigue, changes in stool, such as a change in stool shape or blood in your stool, bloating, abdominal pain, weight loss, changes in your stool habits as well if you're suddenly constipated or you're suddenly having diarrhea. These are the things to look out for. And now there are risk factors for colorectal cancer. The biggest risk factor is just being over the age of 50. This is because as we age, the tissue in our colon and our rectum has regenerated many times over throughout the years, which leaves room for error. And this is true for most cancers. Being over the age of 50 is typically the biggest risk factor. As we get older, we're also exposed to more toxins in our environment and the food supply. 1 out of every 10 adults that are diagnosed with colorectal cancer are in their 40s and under the age of 50. So it's much more common over the age of 50. There are some genetic syndromes, and we will talk about one of the more common ones. So this is something to discuss with your doctor if you think you may have a genetic syndrome. Inflammatory bowel disease, just such as Crohn's disease. This is just due to inflammation and changes in the lining of the colon, and a family history of colorectal cancer. This is a big one as well. Next slide, please. Those with a first-degree relative, meaning mother, father, sister, or brother, who had colorectal cancer are 2 to 4 times more likely to develop colorectal cancer themselves. So in this case, it is recommended to start screening sooner. Typically, you will start screening 10 years before your family member was diagnosed. So let's say your father was diagnosed at 45. It's recommended that you start screening at 35. And now genetic mutations they're not as common as just being over the age of 50. However, there is something called Lynch syndrome, which is estimated that about 1 in 300 Americans have, and they don't know, and about 80% of it don't percent of people don't know that they have it. And this causes 1 to 5 polyps that you develop to have an 80% chance of becoming cancerous. So if for example, if you have a lot of family members who have or had colorectal cancer in your family, it may be worth talking to your doctor about getting genetic testing. But again, we see here that genetic conditions only make up about 4 to 6% of colorectal cancer diagnosis. 30 to 40% of colorectal cancer diagnosis come from having a family history, and 40 to 60% come from ages just being over the age of 50 and older. There are some additional risk factors as well. So African Americans and Hispanics tend to be diagnosed at later stages, usually due to disparities within the healthcare system. Obesity, so each 5-point increase of BMI is going to lead to a 5% increased risk of colorectal cancer and a previous history of cancer or radiation to the pelvic area. So if you have had a previous history of radiation or cancer in the pelvic area, you do need to talk to your doctor because you will have to start screening sooner as well. And now we're going to talk about what I think is the fun part, which is nutrition and eating for good colorectal health. So the most important thing I think is fiber. We really need to be focusing on getting enough fiber. The bacteria in our colon actually ferment the fiber that we eat, and they create something called a short chain fatty acids. And short chain fatty acids have been found to be able to stop cancer cells from developing. Fiber is usually it's going to be found in really any plant-based food. So think peas, carrots, oatmeal, blueberries, beans, and nuts, and seeds. Fiber works in a few other ways as well. I think you probably think of fiber as keeping you regular, and that is true, and it is very important. Fiber actually increases the bulk of our stool, which is going to help it pass a lot easier. It's going to give us easier bowel movements. And actually, this bowel movement is our body's natural detoxification method. So when we eat fiber, it's actually going to bind and transport toxins out of the body in the form of that bowel movement. It's also going to help control, sorry. It also helps control blood sugar, which is especially important for people who are pre-diabetic or type 2 diabetic, but there's some research that shows that everybody benefits from trying to avoid unnecessary blood sugar spikes. So you might be wondering how much fiber. Typically about 30 grams of fiber a day is good to aim for, 35 grams of fiber in a day. Most adults in the US are really only getting around 10 to 12 grams of fiber. And you're always going to be able to see fiber on the nutrition facts label under total carbohydrates. You want to try and aim for foods that have at least 5 grams of fiber or more per serving, because that's going to set you up for success in getting to that 30 grams of fiber in a day. Just remember that if you are not used to eating a lot of fiber, you have to start slowly. Don't, sit down and eat a big bowl of beans. It's not going to feel pleasant later. It can be very hard on your stomach and your colon if you're not used to eating fiber. So add about 5 grams a day or 5 grams a week, and then 5 grams the next week, and so on until you get to that 30 grams. So again, fiber comes from pretty much any plant-based food, fruits, vegetables, nuts, seeds, whole grains. You'll never find fiber in meat and dairy and eggs. Legumes as well is a big one. There are other reasons for choosing whole grains as well. You get some B vitamins, you get copper and zinc, selenium, vitamin E, and all of these work together to help protect our cells against DNA damage. And DNA damage is what can initiate the start of cancer within our bodies. You also get some healthy fats and a little bit of protein from whole grains as well. And now we know fruits and veggies are important for us. They have fiber, but they also have something called phytochemicals. And phytochemical is just a fancy name for plant chemical. And the fun thing I think about phytochemicals is they typically correlate with different colors. So when we think of carrots and that beautiful orange color, that actually comes from the carotenoid, the phytochemical called carotenoid. And they act as antioxidants that again protect our cells from damage. They provide us with night vision and the ability for our eyes to adapt to quick changes in lighting levels within our environment. You can also think of blueberries. That comes from the carotenoid, the phytochemical called anthocyanin. And actually, allicin is a really cool one as well. This one comes from garlic. We recognize it not so much for its color, but for its scent. And garlic has been found to be extremely anti-inflammatory and just really excellent for preventing or lowering the risk for disease and for cancers. A quick tip, if you are cooking with garlic, you actually want to chop or crush your garlic and let it sit for about 10 minutes. And that's going to actually activate the allicin and help it to become a little bit stronger. And then add it into your recipe towards the end of your cooking. You don't really want to add it in right in the beginning when you're sautéing all your aromatics because that does decrease the content a little bit. I recommend just adding it in towards the end. Cook it for about 30 seconds to a minute, just enough to get rid of that very strong taste, and then you're going to get a lot more benefits that way. And now we know that beans are great for us because they have a lot of fiber, but they also have folate. And folate is going to help reduce our risk of colorectal cancer. Folate is a B vitamin that promotes healthy tissue growth in your body and helps our cells divide properly. This is why it's always recommended during pregnancy for our babies, but as adults, we also want these benefits as well, right? So you can find folate in beans and dark leafy greens such as spinach, asparagus, Brussels sprouts, broccoli. Typically, any dark leafy green is going to have some folate. And now, tree nuts, research shows that eating about a handful of mixed nuts can go a really long way in reducing cancer risk and even other disease risk as well. So it's about a handful of mixed tree nuts has been found to reduce the reoccurrence of colorectal cancer in stage 3 survivors by 42%. And it decreased overall mortality in this study by also 57%. So that's very significant. You just want to be careful when you are choosing your tree nuts because sometimes they are salted or sometimes they're caramelized. You really want to just go for plain or low sodium nuts. They are also packed with healthy fats, which are so important for reducing inflammation in the body and for our brain health. So it's a really perfect snack, I think, and a good source of plant-based protein as well. Now, good news for any coffee drinkers. Research shows that coffee can actually reduce your risk of death from all causes by 20% and reduce colorectal cancer death by 18%. So these studies were done on black coffee. So just keep that in mind. You always want to be mindful of how much sugar or cream you're adding in. But in general, coffee is great for us because it comes from a plant, right? It comes from the coffee bean, which is full of phytochemicals and antioxidants. And it also found that this research found that it decreased risk for endometrial and liver cancer as well. And if you're not a coffee drinker, that's totally fine. You can still get these antioxidants from eating a healthy diet. You don't have to worry about the caffeine either if you prefer decaf coffee, you still get the benefits as well. The benefits really just come from the the coffee bean. And so this is the standard American diet plate. We see that there is a really large portion of red meat. There are some vegetables, but there's not a lot of variety in the vegetables. And peas are considered a starchy vegetable as well. And we do have potatoes, which they're loaded up with butter. It looks like they probably have a lot of salt as well. So you really want to try and update your plate a little bit. So the next slide shows us a transitional plate. We're doing a little bit better here. We have a much smaller portion of red meat. We switched out our vegetables for a non-starchy vegetable, such as green beans, and we substitute it for brown rice as well. So definitely a little bit better, but I think we would like for at least 80% of our meals to look like the next plate. So here we have a lot more variety in our vegetables. So remember, we want to try and get as many different phytochemicals as possible. And the way that we can do that is by switching up or adding a lot of variety of vegetables and fruits that we eat. So here we have broccoli, we have some summer squash, zucchini, a little bit of red pepper, it looks like. This is going to give us a great boost of phytochemicals. We switched our red meat for a lean protein, such as chicken, and we have brown rice as well. And the brown rice is going to give us a lot of B vitamins, again, vitamin E, as well as selenium, copper, and zinc, which are all going to help protect our cells from DNA damage. If you do really love white rice, I would just advise watching out for the portion size and maybe doing a blend of brown rice and white rice. And now, of course, there are some foods to avoid. The number one food to avoid for reducing your colorectal cancer risk is processed meat. This is officially known as a carcinogen, meaning that it does cause cancer. And this includes deli meats such as ham, turkey, salami, pepperoni, sausage, hot dogs, really anything that has been processed, smoked, salted. Prosciutto is also one. Chorizo is also one. Studies found that having just 50 grams of a processed meat every day can increase your risk by 20% for colorectal cancer. So 50 grams is just 2 slices of deli meat or a hot dog. It's really not that much. And now red meat is not considered a carcinogen. You do get some benefits from red meat. You get, protein, iron. However, too much red meat can be harmful to our colorectal health. And it is recommended to eat no more than 18 ounces per week, which is, you can break it down to about 3 to 4 to 6 ounces, three times a week. And a good tip for measuring out your portion sizes when it comes to animal protein is actually by using the palm of your hand. In general, this will get you somewhere in the ballpark of 4 to 6 ounces. And now there are other risk factors. Smoking is the number one risk factor for all cancers, the number one modifiable risk factor, meaning it can be avoided. So it's not just lung cancer that it puts us at risk for, it's also colorectal cancer, as smokers also have a poorer prognosis for cancer survivorship than non-smokers. So if, there are a lot of resources in New Jersey if you know somebody or you yourself are trying to quit smoking. And now alcohol is also a risk factor. The Surgeon General, I think, very recently came out saying that that alcohol is directly linked to cancer. And the more alcohol that somebody drinks, the higher their risk is. And if they use tobacco as well, that risk is going to be even higher. So right now the guidelines say that no more than 1 drink a day for women and 2 drinks a day for men of an alcoholic beverage. And so why is it's so important to talk about this. It's important because colorectal cancer can be prevented through screening. More than 60% of colorectal cancer cases can be prevented, which is pretty significant. For every 100,000 people in New Jersey, 39 will be newly diagnosed and 12 will die from this type of cancer each year, which is just it's really concerning because with appropriate screenings and awareness about screenings, 60% of these deaths could be prevented. So here are the screening guidelines. In general, those without a family history should be screened starting at age 45. Screening continues until about age 75. Between ages 76 and 85, it's up to the patient and the doctor to make a decision about screening. And after age 85, screening is no longer recommended. There are a few different screening options. But in general, the gold standard is a colonoscopy. It is the most effective in preventing colorectal cancer because they can go right in and they can search for abnormal areas, they can search for polyps, they can search for cancer, and in most cases they will remove the cancer right then and there or take a biopsy if necessary. And that act of removing the polyp is considered prevention. There are stool tests, such as the Cologuard, the FOBT test, and these have to be done every single year to be considered effective. They do have a higher rate of false positives and false negatives, but they are a good option if somebody really, really does not want to do a colonoscopy. It is important, though, to note that if there is a positive result in the stool test, they will be recommended to go for a colonoscopy. When it comes to the risk of lifetime colorectal cancer, it's approximately 1 in every 22 women and 1 in every 24 men will receive a colorectal cancer diagnosis. So it's really important to know about the screening guidelines, about the preventative measures, and about nutrition, the good nutrition habits that we can all use to try and lower our risk. So in summary, we want to eat more fiber, at least 30 to 35 grams a day of fiber. Focus on whole grains, focus on fruits and vegetables, less red meats and less ultra processed foods and less smoking and alcohol. But the most important thing out of all of this is to go for your regular colorectal cancer screening. All right, thank you so much.
Thank you, Cecilia. That was great. And if you have any questions, please feel free to use the chat. Janet, I would like to have you present now. Thank you.
Yeah, thank you. Great presentation, Cecilia. Good morning, everyone. I'm Janet Acosta. I am here today to present a colorectal cancer screening case. In fact, it wasn't a diagnosis of colon cancer. It was more for the screening referral that came over. So next. So we have this case that it was referred by the gastroenterology, one of the gastroenterology offices that hire nurse navigators to promote and pursue an initiative to increase colorectal cancer screenings in the practice and also in the healthcare system. This nurse navigator identified a patient who was uninsured and needed to have a colonoscopy. So this patient was referred to the NJC program because being uninsured. Unfortunately, this person didn't have the health insurance or any other sources, and also the person didn't qualify for hospital assistance. So that's why when it comes, the NJC made the guidelines for above certain federal poverty guidelines. So we have this patient also had abdominal pain and frequent diarrhea. So usually we don't do refer immediately for any kind of the basic of colorectal cancer screening that we provide to the NJC patients because having the diarrhea will be also increasing the chances of having a abnormal result. Anyway, so this patient never had a colonoscopy or any kind of fecal immunochemical test or those basic tests that are given before a colonoscopy. Next. So we assess the patient. The patient qualified for the NJC program for colorectal cancer screening. So the first step is to hand out a immunochemical test to the patient. So as you also Celia explained, this is an annual test that is given to patients when they go to the family practice as annual screenings above 45. And so this patient also receives the fecal test, and usually you get a stool sample, and the test came out to be abnormal. So it means that it was detected blood in the stool. That's when we proceed and we refer the patient to the gastroenterologist, and where the gastroenterologist goes over with a counseling to try to also assess the patient, any kind of medical, clinical background, genetic, or any type of other history that the patient might have due to these issues that it's having. So the patient, we covered for the colonoscopy. We had funds covered for the colonoscopy for this patient, and while during the colonoscopy, the patient had also a biopsy, and also it was found some polyps. So it was proceeded to perform a polypectomy, which removed the polyps of the colon and the rectum area. During the biopsy, the results were also negative for dysplasia, which means there were no abnormal cancer cells in the biopsy and pathology. The diagnosis of the gastroenterologist to the patient was inflammatory bowel disease. So that's when he came over. The patient had to go over with more surveillance, try to visit more of the practice annually just to see exactly how the GI system, gastrointestinal system is functioning. And the patient also have to go to a specific diet as well and recommended to visit a nutritionist or dietitian to go over to. So next. So there are different, just wanted to mention also, Cecilia mentioned different type of colorectal cancer screening tests. We usually provide the fecal test, or the practices provide fecal test. And sometimes certain practices provide the Cologuard. We're not here to promote any of those tests in here because always the practitioner, the doctor is the one who refers the patient for the best. So we're not here to be consulting to anyone. But these are different options that are there in the practice and also in the market as well. There's so many competitions, and just wanting to emphasize that this is also that can detect certain abnormality in your intestines, in your rectum, but it doesn't diagnose at all colorectal cancer screening. So that's why it's important that, pursue a colonoscopy as part of the screening and diagnosis of colorectal cancer. And that's when the doctor will pursue and recommend the best for the patient. So there are different options, as I said, the fecal test, the Cologuard, which looks for the different DNA changes, and also if there is any blood or in the intestine cells as well. And it has certain type of chances, 93%, I believe, that chances to detect cancer in the colon, colorectal cancer. The fecal test will not, but also there are options for those who don't have health insurance or prefer not to go for an invasive one. But as I mentioned, I would like to emphasize that this doesn't diagnose colorectal cancer screening. And if you have one of those tests, it's important as well to try to look for options to have a colonoscopy. Even if you don't have the health insurance, try to look for the resources to help out to have a colonoscopy. And there's always patient navigators, different programs out there in the community that can help you to assess you and refer you for a colonoscopy or anything that can be covered for those procedures. So it's important that we try to target as well. We can give the options for patients, but at the same time, we're here to also help people, the community, and patients to address the barriers for health for colorectal cancer screening. And that's one of the main factors nowadays, that people don't get screened because they don't have as well the health insurances, and there are other barriers. So they said 3 out of 4 people who died of colorectal cancer screening because they never were screened before. So that's why it's important that you send the message to your family and friends, to everyone, to get screened. So next. So here's some few links about colorectal cancer testing information. Also, we talked about before there. Nowadays, we have a specific blood test. There are tumor biomarkers. Usually, those tumor biomarkers are performed for people who already had colorectal cancer or other type of cancers that can detect either still cancer in some place. Also, the Shield blood test, it's a new type of screening and colorectal screening blood test that as well can detect some kind of colorectal cancer in the system. This is something that is not going to be given to everyone as I read, but you can search more about this specific screen test, and I will tell you exactly who will be able to get this type of screenings. So also we have the other type of blood test that we go annually. We get the CBC when a person has low red blood cells in the system. Also, the person is anemic. There's also indicators that a person is having certain kind of other health issues in the system. And sometimes oncologists refer a person being anemic to either having cancer or not having cancer or might have other type of health issues. So it doesn't really say that, but that's why it is important that other testings are done to perform and diagnose a specific cancer. So none of these will say specifically that this person will have a cancer. So that's why it needs to be more tests to be done. So to conclude in my slides, I always try to encourage people to have colorectal cancer screenings and other cancer screenings that we provide in the different programs in our community and our healthcare system. Always look for help, always encourage your families and friends to have those annual cancer screenings, and especially nowadays that younger people are there and having colorectal cancer screenings before 45 years old. So thank you so much, and I hope that you all learned something interesting today. Thanks.
Thank you so much, Janet. I think we're going to move on to any questions. If anybody has anything, you can unmute, you can put it in the chat. I know I have a question for Cecilia. I know you mentioned how drinking coffee can reduce the amount of dead cell for colorectal cancer. I was wondering if tea has the same effect or any effect?
Absolutely. Tea has been found to have very similar effects. Specifically, green tea or matcha green tea has been found to reduce the risk of cancer and other diseases as well. And that's usually about 2 cups a day is what's recommended for both tea and coffee. Great question. Thank you.
Does anybody else have anything that they would like to ask?
I have a question for Janet. So Janet, colonoscopy versus fit kit, what's the difference between timing of how often those tests should be done?
So I mentioned before, the fecal tests usually are annually. They're given annually until any kind of abnormal results. That's when sometimes the doctor, the provider, refers the patient to have the colonoscopy. But sometimes patients can have their even if they come with normal results in a fecal test, they can really try to go for a colonoscopy if they want. So no one is denied to have any kind of colonoscopy. And then when the patient had a colonoscopy, even if it came out normal, they can have it every 5 or 10 years. Or if the patient was found with polyps, usually they recommend every 5 years. Or even it depends on the type of results in biopsies they found polyps. So it's all about the doctors, the specialists who will tell you, come over. And also because if the patient had genetic and hereditary factors, then the colonoscopy could be done more often than 10 years. So it will be less years to have the colonoscopy. And also I think that's mentioned that the Cologuard, if you have the Cologuard, we heard that is every 3 years. So that's the difference of having the Cologuard and the fecal test. But this is all options and discussions, informed decisions with your provider. So you can research more out there through the evidence-based scientific information, but at the same time to discuss also the options of screening with your provider. Thanks, Evelyn.
Okay, so we're going to go into our post-test. More than 60% of colorectal cancers can be prevented in the US with screening, true or false. Fiber feeds the good bacteria in your gut, true or false. And stool-based testing that is completed on an annual basis is an effective screening tool for colorectal cancer, true or false. So these are all true, with the exception of the Cologuard, which we just learned from Janet is typically every 3 years. But it is true that fiber feeds the good bacteria in our gut, and more than 60% of colorectal cancers can be prevented in the US with screening. Thank you, everybody. Are there any other questions, comments? Okay, so we do have a few resources that we can go through. In our state, we have the NJCED, or New Jersey Cancer Education and Early Detection Program. It's a program run by the New Jersey Department of Health in collaboration with local agencies and healthcare systems. They provide education and outreach within the community about different types of cancer. And they also provide free screening for different types of cancers to those who are unemployed, underinsured, uninsured, or are facing some other barrier to get the screenings that they need. So thank you for attending our session today. We did put a link to our survey in the chat, and there's also a QR code. So you can use your phone, scan the QR code with your camera, and it'll take you to the anonymous survey as well. We really appreciate your feedback. Let us know what you thought of today's session. If you have ideas for any other sessions that you would like to see, we're totally open to hearing your suggestions.
And
Thank you
as
so much.
always, these resources are going to be posted on our Mighty Networks. I saw that Stephanie mentioned a recorded webinar. So basically on Mighty Networks, there's a discussion platform and an announcements page. Stephanie, if you want to join the Mighty Networks and drop the link for the webinar so everybody can watch, it's a great way to discuss with each other. You can reach out to any of the presenters today as well. And I'm going to put the link for that in the chat now. And join us on April 9th for a session on sun safety. We're going to go over everything skin cancer. Thank you all for
Thank you
coming,
so
and thank
much.
you for our speakers. Thank you for coming. Yes.
Yeah, thanks, Sarah, Cecilia, Evelyn, everyone.
Thank you, everyone. We'll see you next time on April 9th.